We can.
Okay. All right. So today we're going to talk about hepatitis C. We did B last time, and today it's Hep C. So the virus itself is one of a family of virus, and it's of the Flaviviridae, which is the same species as yellow fever, West Nile, and dengue. They're analogous viruses. And one of the unique things about Hep C is that certainly in the viral world, if you look at the timeline, the virus was discovered in 1989, and in a span of basically 35 years, uh, actually 25 years, we went from the discovery of the virus to the cure. And that timeline is extraordinarily rapid. I can't think of certainly any viral disease where the cure, not the prevention, but the cure has been achieved in such a short period of time. And ultimately, these investigators, Houghton, Alter, and Rice, received the Nobel Prize. They were the ones who identified the virus and developed the antibody test for the virus. So the magnitude of the problem is shown here. There are nearly 4 million people in the U.S. who are infected by Hep C, and we get about 35,000 cases yearly. 85% of those who develop Hep C acutely become chronic. And that chronic hepatitis C infection is a leading cause of, chronic hepatitis, cirrhosis, hepatocellular carcinoma, and currently still remains the number one cause leading to liver transplantation. It will be supplanted probably by metabolic associated chronic liver disease, but Hep C is still the number one. So, who are those at risk for developing it? Anyone who was transfused before 1992, which is when the virus was identified, intravenous drug users, nasal drug users, uh, patients on long-term dialysis, the prison population, any exposure to blood products, of course, transplantation from an HCV positive donor, and potentially tattoos and body piercing are causes, obviously depending upon whether infected instruments or material is used in the process. The prevalence by age goes along with the fact that intravenous drug use is the major risk factor. So it's very, very uncommon in children. As you can see here, less than 11 years of age, a vanishingly small percentage of children will be anti-HCV positive. And sort of the peak will be in the third and fourth decade of life, which is the peak for intravenous drug use, obviously. If you considering those children, now adults, who would be at risk, up to 95% of children with a thalassemia or hemophilia who received blood products before 1990 are HCV antibody positive. That does not mean they're necessarily infected, but they're HCV antibody positive. And the magnitude of that problem is that if you go back before 1992, 500,000 NICU infants had received transfusions. So, one thing that you all should remember and note, while the vertical transmission rate, which is really the number one way that children become exposed, that transmission rate is only 5% unless the mother is also HIV positive. Then, depending upon the study you look at, it's somewhere between 7 and 10% transmission. So it's not a high transmission rate regardless, but that transmission rate is enhanced if the mother is also HIV positive. Unlike hepatitis B, where the majority of patients will resolve, spontaneous resolution in Hep C is uncommon. Only 15% of acutely infected individuals will spontaneously resolve their infection, while 85% will become chronically infected. The natural history, again, if you go from the upper left to the lower right, 15% are resolved and 85% have chronic HCV. Of those with chronic HCV, the vast majority are stable over a long period of time without any progression of disease. However, 20% will develop cirrhosis, and of those, a quarter will develop either hepatocellular carcinoma or liver failure, resulting obviously in liver biopsy, liver transplantation. And then the vast majority, 75% of the cirrhotic patients will have slowly progressive disease. And if one is going to spontaneously clear, that is most commonly going to occur in the vertically transmitted infant. So 20 to 40% of infections will resolve if acquired perinatally. If one acquires the infection later in life, the spontaneous resolution is vanishingly small. And again, the clearance rate for newborns who have vertical transmission will be less if they remain HCV RNA positive after the first year of life. And these are important age points to remember as we go on to discuss who and when to treat. So this is a view of the virion itself. It's an enveloped glycoprotein. Hep C is an RNA virus in comparison to Hep B, which is a DNA virus. And there are a number of important constituents, which include both structural and non-structural proteins. Here, the structural proteins are shown in the reddish orange, and the non-structural proteins are in the blue. These non-structural proteins, which include RNA polymerase and proteases, are the targets of the direct-acting antivirals. The reason that HCV has been so difficult to treat is because of something called the hypervariable region. The hypervariable region is shown here to the left. And this is something that the virus constantly undergoes minor genomic changes without affecting its infectivity. But this hypervariable region, these genomic changes, make the virus very difficult to treat. Obviously, the hypervariable region is in the region of the structural proteins. And because the direct-acting antivirals target non-structural proteins, this then avoids the problem of the hypervariable region, which was a big problem when the only treatment we had was pegylated interferon and ribavirin. In terms of the viral replication, it's tightly linked to cell lipid metabolism. The enveloped glycoproteins are the determinants of cell injury. It enters via clathrin-coated pits via endocytosis. And once the virus is taken up by the cell, it induces a rearrangement of intracellular membranes into something called the membranous web. This membranous web is closely associated to cytosolic lipid. And in fact, steatosis is one of the hallmarks of the histopathologic findings in hepatitis C. The virus then is an RNA virus, and it recruits multiple host factors to replicate its genome. Again, the assembly of the virus occurs in close proximity to cytosolic lipid and appears to be also closely linked to the synthesis of very low density lipoproteins. So here is a depiction of the viral replication. Again, it's taken up by the cell via clathrin-mediated endocytosis. The RNA is uncoated, leaving a nucleocapsid. This goes to this membranous web associated with cytosolic lipid, and the virus is then reconstructed and released. The two major targets of the direct acting antivirals are, of course, the protease inhibitors and the polymerase inhibitors. Protease inhibitors prevent viral replication by binding to specific viral proteases that prevents the synthesis of precursors that are essential for viral replication. The polymerase inhibitors, of course, will prevent the transcription of the RNA-dependent RNA polymerase. The virus itself has an extremely high replicative activity, although it has a half-life of only a few hours. When the body is infected with it, you produce and clear about 10 to the 12th virions per day. Now, one of the things, our DNA has proofreading capabilities. So when there's a problem with DNA replication, we get rid of it. But that's not true for the virus. The HCV RNA polymerase lacks proofreading activity. And sometimes there are lethal mutations which create a non-functional virus, although there are quasi-species which have minor genomic changes and they change over time in each infected host. And again, these quasi-species are largely represented by changes in this hypervariable region, which do not affect infectivity or function of the virus, but certainly affect our ability to treat, again, prior to the development of the direct-acting antivirals. These quasi-species have nucleotide homology of greater than 95%, so only minor changes in the genome. Specific genotypes, and there are a number of them, have a sequence homology of less than 80%, and these develop really over decades or centuries. And so there are three major genotypes, and the major importance of these genotypes, again, prior to the development of the direct-acting antivirals, is that each of these genotypes had a different sensitivity to treatment with pegylated interferon and ribavirin. The least sensitive was type 1, which is the most difficult to treat, whereas type 2 and type 3, which comprise a smaller percentage of the total genotypes in the US, were more readily treatable via pegylated interferon and ribavirin. So again, in the US, genotype 1 comprises 70 to 80% of isolates, while the remainder are 2 and 3. Again, the clinical significance of these genotypes is not clear, except as a function of their response to pegylated interferon and ribavirin. In other words, if you look at the response to that treatment, only 40 to 50% of patients with genotype 1 will respond, whereas 79 to 80% with genotype 2 and 3 will respond. However, since genotype 1 is the most common in the US, you can understand the magnitude of the problem prior to the development of the newer class of drugs. One of the problems with HCV, and we talked about this with hepatitis B, where really liver biopsy is not incredibly important in the management of most patients with Hep B because enzymes usually reflect the level of involvement. This is not true with HCV. You cannot tell by looking at transaminases whether or not someone is going to be more or less affected. This slide looks at the log HCV RNA in the y-axis versus the level of either no fibrosis to the left on the x-axis to cirrhosis to the right. And if you look at the log HCV RNA, it doesn't change, regardless of genotype. So there is no correlation between viral load and the development of fibrosis or cirrhosis. Similarly, serum HCV RNA does not correlate with the level of inflammation. So if you look at the inflammation score on biopsy on the x-axis versus log HCV RNA on the y-axis, again, no correlation. So looking at the numbers serologically, there's no way of knowing how affected the liver may be. What we do know is that the risk factors for cirrhosis are directly related to the years after viral exposure. The longer the duration of infection, the older your age at the time, the older you are at the time of exposure, whether you're a male, whether you have underlying liver injury, or whether you have an advanced histologic grade on biopsy initially, that's going to determine the risk factor for cirrhosis. And as you can see in the graph, over time, there's an exponential increase after about 10 years of exposure. So the progression to cirrhosis occurs in about 20% of patients after 20 years, and the mean time to the onset of cirrhosis is about 18 years. So it's a very long period of time between exposure and progression to cirrhosis. Again, injection drug use is the primary mode of transmission in the US. It's not transmitted by means other than by direct exposure to blood products. By the way, breastfeeding is not a contraindication for patients, for mothers who are hepatitis C positive. So, what can we do in order to manage patients who are exposed? Well, we can try to look at transaminases, bilirubin, albumin, INR, platelet count, liver histology. But again, the AST is very helpful. And of course, we would like to treat patients before they go into subacute liver failure, which would be manifested by jaundice, hypoalbuminemia, and a prolonged INR. So LFTs themselves may not inform on the need to treat or just to monitor. The response to therapy, again, the ALT is not going to be a sensitive indicator. HCV RNA, certainly we want to follow over time. And genotype is important in this case because the genotype will determine the specific direct-acting antiviral therapy that you are going to recommend at all ages. And then finally, of course, liver histology will inform on the extent of disease. The role of diagnostic testing in these patients is to identify those with infection, whether they've had previous exposure, active infection, inactive, or resolved, and then assess the response to therapy to evaluate them prior to the onset of treatment and during and following treatment. The modes of detection are basically two. One is the looking at anti-HCV antibodies. The other is a direct virological assay. The sensitivity is high for both serological and virological testing, but the specificity varies dramatically. The virological tests, the extent of the amount of virus you have in the bloodstream is very specific for the infection. However, serological testing is much less reliable. If one wants to evaluate patients, detection post-exposure, you would want to evaluate them serologically 2 to 6 months after exposure. Virologically, within 6 weeks, you'll be able to determine whether they've been acutely infected. In general, serological tests are used for screening, while virological tests are used for confirmation. What about HCV antibodies? Well, the HCV infects the cell. These HCV proteins are expressed on the surface of hepatocytes, and then antibodies to these HCV proteins are produced by your host lymphocytes. So despite the fact that you have all these HCV antibodies circulating around, these antibodies do not convey immunity. What they do is give a setup for other manifestations of disease. And so the immune manifestations of HCV are a direct result of antibody production. The virus itself evades the immune response, and we have chronic immune stimulation by the virus, leading to the production of all these antibodies. In combination with genetic and environmental factors, a number of other antibodies can be produced. These can include anti-nuclear antibody, rheumatoid factor, and one of the big problems is that one develops cryoglobulinemia, cryoglobulins, which trap HCV. These result in a mixed cryoglobulinemia. The HCV has a predilection to infect B cells. As a result, we have a reduction in cell apoptosis or cell death with prolonged lifespan of these lymphocytes. We have an increase in their antibody production. This results in a cryoglobulinemia and also may lead to neoplastic transformation. Anytime you have aged cells which refuse to die, that sets one up for malignant transformation. In this case, a higher risk for B-cell lymphoma. Symptomatic cryoglobulinemia also becomes extremely important. So many patients with HCV will experience other manifestations of autoimmune phenomena, including Raynaud's phenomena, development of skin breakdown, neuropathies, and other problems related to the symptomatic cryoglobulinemia. So if one's going to use anti-HCV antibodies, again, they're quite sensitive. It's an enzyme-linked immunosorbent test or ELISA test, which can detect circulating antibodies. However, one has to be aware that false positive reactions may occur. And there are also cross-reacting circulating antibodies, which may non-specifically bind to anti-HCV. The positive predictive value, again, PPV is total positives over total positives plus false positives. If one has risk factors for HCV, the antibody test is quite specific. Without risk factors and in normal ALT values, however, the antibody testing is much less sensitive and specific. False positives occur in patients with other autoimmune disorders and also with spontaneous resolution of viral infection. You're still going to be HCV antibody positive, even though you have no virus circulating in the bloodstream. False negatives will occur in a variety of situations, mostly those that are involved in some level of immune suppression. Also, patients who are HIV positive may test negative for the antibody. So when do we do a PCR? What are the indications for RNA testing? You want to confirm infection in patients with persistently normal ALT values. Patients who have no risk factors, again, with risk factors, the antibody test is quite valuable, much less so with no risk factors. Patients who are HCV antibody positive as a confirmatory test. Patients who are ANA positive, remember the cross-reactivity with other autoantibodies. And of course, prior to initiating therapy. You're then going to follow up with HCV RNA testing to predict the likelihood of response before and during therapy and to confirm the response after therapy is completed. Despite the fact that over a long period of time, one can develop cirrhosis or chronic liver disease, generally, most patients have a stable HCV RNA level over time until the virus is eradicated. Unlike hepatitis B, where there can be marked swings in the viral load, patients infected with HCV tend to have a stable viral load over time. If we look at the response to acute infection, it's highly variable. Here, the red graph are those who resolve their infection, and the blue graph are those who are chronically infected. And as you can see by the blue graph, the ALT is all over the place, including a long period where it may be normal. And if we look at patients with chronic HCV, they may have intermittent flares of their ALT. That is in the light blue. They may always be normal, or they may have a single elevation that you may have to catch at one time or another. So again, the ALT itself is not a good predictor of disease severity or even whether or not someone is going to progress to cirrhosis. The ALT is unhelpful in determining the need for therapy and follow-up. If we look at patients with normal ALT and elevated ALT, there are clear racial disparities. Here we have the difference between white and black patients. Those with normal ALT tend to be much greater in the white population, whereas blacks infected with HCV have a higher likelihood of having an elevated ALT. The serum ALT concentrations, however, even those with elevated ALT, tend to be no more than twice normal. As you can see by the middle graph here, the serum ALT in normal ALT patients is 46 versus 76 in those with elevated transaminases. Despite the fact those with normal ALT and elevated ALT have no difference in their viral load. However, with an elevated ALT, there is a slightly greater predilection for an increased inflammatory score and a greater predilection to advance to fibrosis. So when one has an elevated ALT, that may suggest an increased risk for developing a chronic liver disease, ultimately with cirrhosis, but doesn't preclude the fact this can also happen in patients with normal values. So how do we interpret these assays when put together? So if the anti-HCV antibody is positive and HCV RNA is positive, this indicates either acute or chronic infection. If the anti-HCV is positive and HCV RNA is negative, that implies resolution of infection, or it can be acute infection during periods of very low level of viremia. Remember, these viral tests are not absolute and have a lower limit of detection. If anti-HCV is negative and HCV RNA is positive, that's early in the acute infected stage, or could be chronically infected in an immunosuppressed state, or could be a false positive. Only if both are negative does that clearly indicate the absence of HCV infection. The AASLD has come up with recommendations as to how we should evaluate children, particularly children with perinatally exposed HCV. So all children born to HCV-infected women should be tested for infection. Testing is recommended using an antibody-based test. Remember, these are children at high risk because their mothers were HCV positive at or after 18 months of age. Why 18 months of age? Well, of course, the HCV antibody is an IgG antibody. It's going to be transplacentally transmitted to the infant. So all infants born to an HCV antibody positive mom are going to be HCV antibody positive. So you have to wait until the normal half-lives of the IgG wane so that you can determine whether or not the infant, him or herself, is producing antibody. Testing with an RNA assay can be considered in the first year of life, particularly in very high-risk situations, but there's no timing that's been recommended. Again, when one has a very high-risk situation, I guess one would use the situation of a child born to an HCV and HIV positive mother. You may want to engage in earlier testing. Normally, though, testing prior to 18 months of age is not recommended. Children who are anti-HCV positive after 18 months of age should have an RNA test to confirm infection, as should all children with all siblings of children with vertically acquired HCV. So why biopsy? Again, we've learned that The viral load may not be predictive of disease. The ALT is certainly not predictive of disease. The liver biopsy can provide helpful information on the status of liver injury. It identifies features useful in the decision to embark on therapy. And again, patients with a normal ALT may already have advanced fibrosis or cirrhosis that would necessitate immediate therapy. And there's a variety of histopathologic findings. Here, panel A just shows some increased parenchymal inflammation, the very dark blue stained nuclei you can see here, and the portal area really looks pretty good. In panel B, remember we said that the virus replication is closely associated with cytosolic lipid. And so here you see the steatosis, which is characteristic of hepatitis C, which again should lead one to believe that HCV may be a particular problem in patients with metabolic associated chronic liver disease or fatty liver disease. And indeed, they are at higher risk for developing complications from HCV. And here you can already see the portal area has expanded. There's some loss of the limiting plate and some advanced fibrosis. Here again, panel C and D show the case of a cirrhotic liver at various stages of the disease. And even here in panel D, you can see there's a lot of fat here within the parenchyma, again, because of the linkage between cytosolic lipid and HCV viral replication. Genotype 1, which again is the most common genotype seen in the United States, was historically the most difficult to treat. 25% of patients with HCV genotype 1 already have significant fibrosis, even with normal transaminases. And furthermore, treatment response is similar to patients with higher ALT levels. So again, remember when we talked about hepatitis B and we talked about the immune tolerant situation, very high viral load, low transaminases don't treat. Throw that theory out the window when it comes to HCV. The ALT neither informs on the severity of disease, nor does it inform on the likelihood of patient response. Prior to the development of direct-acting antivirals, the only factor that was directly related to the likelihood of responding to therapy was genotype. So to review again, these are the drugs, and I've added a few at the bottom. Remember, they are either protease inhibitors or polymerase inhibitors. And then number 2 at the bottom is something called an NS5A inhibitor. NS5A is a protein essential for viral replication. These are all non-structural proteins. Of course, the protease inhibitors will act much more proximally. These are the drugs that are shown here, and they can actually affect the glycoprotein breakdown of the virus. The NS5A inhibitors, again, will block a protein essential for replication, and the polymerase inhibitors prevent the replication of RNA. The way we evaluate patients in terms of treatment is that, again, the goal here is disease cure, eradication of the virus. And there are 4 basic categories. There's the sustained virological response, where you have undetectable HCV RNA 24 weeks after the discontinuation of therapy. We have an early viral response, which is an undetectable viral load or a marked decrease in viral load at week 12 of therapy. A rapid virological response, this is undetectable RNA at week 4, and an end of treatment response, which is undetectable virus at the end of a full therapeutic course. So obviously, the best thing would be a rapid response with a sustained virological response. The first drug or combination of drugs that was developed and studied extensively in adults is Harvoni. Harvoni combined ladipasvir, which is an NS5A inhibitor, and sofosbuvir, which is an RNA polymerase inhibitor. And of those patients, in non-cirrhotic patients with a low viral load, 98% had a sustained virological response, independent of genotype. Patients who were non-cirrhotic but with a high viral load, the same. Compensated cirrhotics, the same. What was the only thing that was different among these three groups was the length of therapy. In the first case, 8 weeks of therapy. In the following two cases, 12 weeks of therapy. If we look at Harvoni at 8 or 12 weeks in genotype 1, in treatment-naive, non-cirrhotic subjects, here we have the sustained virological response at week 12. All right. Here is 8 weeks is orange, 12 weeks is blue. And you can see here we have really incredibly effective therapy. But let's look at relapse following 8 weeks of therapy or 12 weeks of therapy. Again, orange is 8 weeks, blue is 12 weeks. Clearly, those with a high viral load given 8 weeks of therapy are more likely to relapse than those with who are given 12 weeks of therapy. And this sort of is the basis for treatment, and not a change in drug, but a change in the length of therapy. So those patients with a high viral load would certainly benefit from 12 weeks of therapy. Indeed, the current recommendation is for all patients with genotype 1 who are treatment naive and non-cirrhotic should have 12 weeks of therapy. But what about children? Well, again, keep in mind that HCV is a very long-winded disease. It takes a long time to develop problems related to chronic infection. Indeed, there are no FDA-approved direct-acting antivirals for children less than 3 years of age. Furthermore, again, because of the time nature of the infection, cirrhosis or hepatocellular carcinoma are very rare in childhood. Patients with HCV, children with HCV rarely have to undergo transplantation. And obviously, we'd like to avoid interferon-based therapies, which are approved for younger children because of their unfavorable side effects. And because, again, the length of the infection allows us to wait a longer period of time before initiating therapy. We do, however, want to treat children who are 3 years of age and older to prevent future cirrhosis and hepatocellular carcinoma, and obviously also to prevent the stigma associated with chronic infection. Could one wait a longer period of time? Remember, in adults, the mean period of time before the onset of cirrhosis is 18 years. So we really could wait until adolescence before treating most pediatric patients. But again, greater than 30 years of age greater than 3 years of age with active infection, we would want to treat. So the recommendations, again, have been developed by the AASLD. Direct-acting antiviral treatment with an approved regimen is recommended for all children greater than 3 years of age, as they will benefit from antiviral therapy for the reasons I just outlined, regardless of severity. And of course, remember we talked about the extrahepatic manifestations, such as cryoglobulinemia, dermatologic effects, and also kidney disease as a result of immunoglobulin manifestations. So the presence of extrahepatic manifestations, as well as the presence of fibrosis, should lead to early antiviral therapy and to minimize future morbidity and mortality. Now, I'm not going to go through all of these drug regimens, but depending upon the genotype and depending upon the age and weight of the subject, that is going to determine whether one uses a combination of ledipasvir and sofosbuvir, veltapisvir, glecaprevir, and permatasivir, and on and on and on. So I would encourage you to look at the AASLD recommendations when you have a patient with HCV, and they will provide the guidance that you need to treat. And remember, the treatment regimen can go from 8 weeks to 24 weeks, depending upon the genotype. So for genotype 4, 5, or 6, 12 weeks of therapy. For 1, 2, 4, 5, or 6, we can use a different regimen for 8 weeks. So the therapies go from 8 weeks up to 16 weeks, again, depending on genotype. And there may be a number of options for each genotype. And so one is generally going to do whatever is sort of current practice wherever you will be practicing. But again, it will determine the genotype, whether you're treatment naive, with or without cirrhosis. What do we do with families? Well, parents should be informed that hepatitis C is not transmitted by casual contact, and HCV-infected children do not pose a risk to other children and can participate in school activities. Parents should also be informed that universal precautions should be followed at school and in the home of children with HCV infection, and we need to educate about how the disease is transmitted and techniques for avoiding blood exposure. Now, clearly, for most of us, this is not going to be a problem, as we see very few patients, certainly with vertically transmitted HCV, but these are the kinds of things that we have to educate parents about. So how do we monitor and manage HCV-infected children? Well, we want to do routine biochemistries, and at least annually. Appropriate vaccinations are recommended for HCV-infected children not immune to hepatitis B virus. For patients who are at risk for developing hepatitis B or have hepatitis B, HCV treatment can actually reactivate hepatitis B. So we want to make sure that all our patients, before we treat them, are hepatitis B immune. So how do we assess disease severity? Well, we can use routine laboratory testing and physical examination. However, we all know from the previous reports that looking at the ALT or other transaminases is not going to be reliable. So we have to look at other things. Can we use imaging, liver elastography, or should we be doing biopsies? Probably a screening initial liver biopsy is not a bad idea in patients with HCV infection, and may also inform on the long-term prognosis for patients with HCV. Children who've already developed cirrhosis should undergo hepatocellular carcinoma surveillance and endoscopic surveillance for varices. Again, we try to avoid hepatotoxic drugs in patients with chronic HCV. Although organ transplantation and bone marrow transplantation are not contraindicated in children with chronic HCV, hopefully we treat these patients and the disease resolves. And what kind of organ transplant would you be considering in chronic HCV? Well, it would be the consequence of chronic HCV, but still, it's not a contraindication. And of course, anticipatory guidance about the risks of the use not only of hepatotoxic drugs, but also of ethanol. And all patients with HCV should practice abstinence from alcohol. So we're going to conclude with a case. Dr. Kine, want to read this one?
Sure. A 6-month-old full-term healthy female born via normal spontaneous vaginal delivery attends a well-child check. Pregnancy and birth were uncomplicated. Her mother has a past medical history significant for untreated hepatitis C. She is HIV negative. At the request of the parents, hepatitis C testing was done at 6 months of age, which demonstrated hepatitis C virus antibody reactive, viral load of over 18 million. The best next step is A, begin treatment for hepatitis C, B, test infants for, I'm sorry, B, test infant for C antibody. It's blocking my view. At 12 months of age, test infant for hepatitis C RNA at 12 months of age, and then repeat HCV antibody at 18 months of age. Um, I'm going to go with D, repeat the test at 18 months.
Why?
Uh, so, I mean, from your talk also, and then I just remember this from uh from reading somewhere. I can't remember why. Just remember that fact.
The It could be maternal IgG, but I was a little bit confused by the virus part, that there was a viral load as well. Because like
There's the reasons.
This is also something that pops up very frequently on the pediatric boards.
It does. There are no direct acting antivirals approved for this age group. Spontaneous viral clearance is high in children less than 3 years of age.
okay.
And the risk of significant liver disease due to HCV less than 3 years of age is very low. So again, this is a high risk situation. And because it's a high risk situation, the antibody test is a good screen, but you don't want to screen them until such time as you know if the antibody is positive, the antibody is being produced by the patient, not by the patient's mother. Got it?
Yep.
Yep, I know, I know. Yep.
Okay.
Thanks.
Monday will be 10 o'clock board review. And I'm going to stop
Sounds
sharing my
good.
screen.
See you Monday then. Thank you.
Thanks, Dr. Schwartz.
Thank
Thanks
you.
everybody else for joining us. For applicants, if you came in, I apologize if I was slow on the letting you into the session. Otherwise, we appreciate you coming back to take a look at things. And once again, just as a reminder, all these lectures do get uploaded to our YouTube channel. I just uploaded a few more today, so you can join the many, many people watching Dr. Schwartz online as one of our biggest influencers in the area of highly technical lectures about the pediatric intestine and liver.
So Monday's board review, 10 o'clock, 10 o'clock.
Yes, we're going at 10 on Monday. Remember that, fellows, 10 o'clock. Dr. Schwartz has other stuff he's got to get to, and you've got to show up and take the emotional beating.
Don't worry, we're all there to support you.
Yep.
All right, guys. Thank you.
Pathology today.
Then.
Right.
Bye.
Thank you.
Well, I think we do have Path today, yeah?
No, Meredith said she was on vacation
No, we
this
don't.
week.
You're right.
No, we
Aaron's
don't.
out. I saw that email. Okay, we'll have Path next week then, man.
All right.
Hey.
Thank you.
All
Thanks.
right. Bye, everybody.
Bye-bye.
Bye.